So for those who are not familiar with Dr. Penny, Penny is a naturopathic doctor in Toronto. After graduating from McGill University with a Bachelor of Science in Neurobiology, she earned a degree in naturopathic medicine from the Canadian College of Naturopathic Medicine, where she received the Dr. Alan Tyler Award for Most Outstanding Clinician. In 2013, she was voted Naturopath of the Year by her peers and colleagues. And Dr. Kendall Reed is also the co-author of 5 national best-selling books, including The New Naturopathic Diet. And she travels throughout the world lecturing on neuroendocrine-related diseases, metabolic disorders, and genetics. She's also currently the director of natural therapies at the Urban Wellness Clinic in Toronto. And how I like to describe Penny is that you can't get her talking about any health topic without getting her into the topic of genetics. So without further delay, I'll now pass the following time to Dr. Penny. Dr. Penny?
Thank you so much, Denise, and thank you everybody for joining me this evening or this morning on our side of the world. Really looking forward to going through thyroid disease and why it really is on the rise, and particularly so in China. This is just a disclosure. As Denise mentioned, I am also an advisor for Atrium Innovations, Pure Encapsulation, Douglas Laboratories, and Pure Genomics. So getting right into it, thyroid disorders, they're on the rise worldwide. However, the growth in numbers is rising faster in China than most other places in the world. In fact, over 19% of women in China in their childbearing years have a thyroid disease. And it's not just the adults. The percentage of kids under the age of 15 in Hong Kong with a thyroid disorder, specifically the autoimmune thyroiditis or Graves' disease, is continually rising. And it's now 5 times higher in Hong Kong than anywhere else. The main reasons for why there is a rise in thyroid disease, just worldwide, not just in China, there's stress and pollutants and how they impact the body. Toxins have a great impact on thyroid function, either increasing or decreasing specific thyroid hormones. And unfortunately, China ranks as one of the highest polluted countries, second only to India. Chronic stress also directly affects thyroid function, but it also indirectly impacts the thyroid as it excites the immune system, increasing autoimmune factors that lead to thyroiditis. So it's no wonder that 70% of those diagnosed with a thyroid disorder are diagnosed following a really stressful period of time. Iodine deficiency used to be blamed for a great deal of thyroid issues, but that doesn't really hold true anymore due to awareness and fortification in foods. Genetics, however, though, contributes to 80% of the development of Graves' or autoimmune thyroiditis. And again, this is really prominent in China because there's a higher percentage of variants or abnormal coding within the thyroid genes in China. So this is just a really quick review of the thyroid feedback. We all know that the thyroid is controlled through the hypothalamic pituitary thyroid axis. So the hypothalamus in the brain tells the pituitary in the brain to release that TSH to stimulate our thyroid to make T4 and T3, mostly T4, and then the T4 goes into our peripheral tissues, mostly the liver, gets converted into T3. When those levels get high, then what will happen is the T4 and the T3 feed back onto the hypothalamus and the pituitary saying, great, I've got enough in my blood. Let's stop stimulating this pathway so we stop making more of those thyroid hormones. This is absolutely no different in terms of its physiology to the hypothalamic pituitary adrenal axis that we see in the stress pathways, and this is why the two of them are so interconnected. So, what happens when this axis goes awry? Well, hyperthyroidism, defined as an overactive thyroid that produces too much thyroxine, or T4, is generally grouped into one of 4 main causes. Graves' disease, which is also known as toxic goiter, is the most common, and this is the autoimmune version of hyperthyroidism. We also have toxic adenomas, which are benign tumors on the thyroid that cause the thyroid to increase the production of the thyroid hormones, and these tumors can be active or inactive. We have subacute thyroiditis, which is just inflammation of the thyroid, and it's often secondary to a viral infection that then stimulates a slow release of those thyroid hormones, increasing hyperthyroidism. And this is usually self-limiting. It'll last often weeks to months. And then, of course, we have cancer of the pituitary, which clearly will increase the production of those hormones. Symptoms that we see here is everything is in overdrive. The blood pressure is up, our heat is up, our eyes start to bulge. We have an increased heart rate, our bowel movements are faster, our weight loss is faster. Everything, as we know, in hyperthyroidism is in high or overdrive. Hypothyroidism, at the opposite end of the spectrum, is where we have an underactive thyroid, which results in lower thyroid hormone production. And again, it's usually due to one of four main mechanisms. Hashimoto's thyroiditis is the #1 cause of hypothyroidism, and it's also an autoimmune condition whereby the immune system relentlessly attacks the thyroid until the tissue degrades and dies and stops producing sufficient hormone. We also have thyroidectomies, and these are secondary to cancer or cancer treatments. We also have increased exposure to excessive iodine, which is usually coming through people who are abusing cold and sinus medications, that's the #1, or certain cardiac meds or dyes, contrast dyes that are used in things like CT scans and different imaging. And then we have chronic stress, which we'll really get into, the #1 cause of all autoimmune thyroid conditions, both hyper and hypo. Clinically, what we see here is the opposite type of pictures. Everything is slow. So we have our mood is low, our skin is dry, our bowels are slow, even our blood pressure drops. Everything gets slowed down. When it comes to diagnosis, a complete picture is really key. Testing only TSH, which a lot of docs will do as a first line, is not sufficient. We know that when we have an overactive or hyperthyroid, our TSH is low because it's trying to say, don't stimulate the thyroid more, don't stimulate it, we have enough going on. Then we have quite a wide spectrum for a normal range from 0.3 to 5. And then when it gets into the hyperthyroidism or overactive, our TSH levels start to rise high. I'm sorry, the opposite, the underactive thyroid, it starts to rise high. So it's really important, though, that we combine the TSH levels with all of the other blood levels, our T4, our T3, our reverse T3, our antibodies. And I'm not going to go through the reference ranges here because that's something we can easily do on our own, and most of us know these reference ranges. It's just so that we have this for completeness. What I really want to get into is why the thyroid goes off and then what we're going to do about it. So let's jump right into it. We saw that our environment plays a huge role with respect to the thyroid. And again, as China being rated second in terms of pollution, this becomes really important. But each toxin has a specific effect on thyroid function. So we have perchlorates, which are found in commercially produced salts, and they're used for packaging and processing foods. We have thiocyanates. They're found in some good things like cruciferous veggies, but also in some bad things like cigarette smoke. We have nitrates used to preserve deli meats, and all of these inhibit the uptake of iodine, which is needed by the thyroid to produce and convert T4 into T3, so into that active form of the thyroid hormone. We also have PCBs, bisphenol A, and triclosans. Triclosans might not be as well known, but they're found in a lot of our daily products. Things like soaps and detergents and clothing fabrics. And what all of these do is inflame and damage the thyroid hormone receptor in various tissues. So it won't allow the thyroid hormone to bind in and perform its function. And all of that's independent of the amount of thyroid hormone that we have in the body. And then we have isoflavones, which are found in soy products. And these can inhibit TPO activity, which are thyroid peroxidases. And these are the enzymes that are needed to oxidize iodide ions to form iodine ions. And the iodine ions, as we know, are needed to make that T3 and T4. So ultimately, too much of the isoflavones will lower our T3 and T4 counts. We also have PBDEs, or polybrominated diphenyl ethers, and these are found in those flame retardant materials, things like furnitures and rugs, airplane seats, clothing. We also have the isoflavones again here, and those perchlorinates that we saw in the commercial salts, as well as BPA in the plastic products, and these all directly inhibit the production of T4 and T3. There's also organochlorine pesticides. They're found on many of our foods, and dioxins and furanes, which are on byproducts of waste materials or burnt fuel. All of these activate the liver enzymes to degrade T4 more quickly, reducing its half-life and thus reducing the time that it has to actually perform its main role in converting into T3. And then there are several toxins such as styrenes used in fiberglass or rubbers or automotive products, boat parts, etc., and sunscreens, and they'll have a bevy of different effects on the thyroid, all leading to a lower thyroid production. We also have some lesser known disruptors that we might not think of as bad. Quercetin, which is an incredible bioflavonoid for mast cell stabilization, etc., but it can inhibit the iodide uptake, again, lowering T4 into T3, and also decrease thyroid growth and repair, and it changes the expression of thyrotropin receptors, again, altering the function of the thyroid. Then we also have resveratrol, which I love for so many different things. Resveratrol, though, inhibits a lot of different genes. It's great for inhibiting PPAR, so help with our metabolism. It inhibits the production of interleukin-6, but it also inhibits sodium iodide symporter genes, which is SLC5A5, and that inhibits the uptake of iodine into the follicular cells of the thyroid, this being the first step of thyroid synthesis of the hormones. So this is just a handful of potential toxins in our daily environment. And these aren't the toxins that are just in trace concentrations or ones that only people working in certain industries are exposed to. These are everywhere. And the higher the concentration in the air, the more potential for thyroid dysfunction. So let's take a look now at the autoimmune side of things, seeing as that's the most common cause of both hyper and hypothyroidism. First, we have Graves' disease, which is known as toxic goiter or as thyroid mimicry, and it's defined as a low TSH with or without an elevated T3 and T4. But the biggest defining feature is something called a high TSI, or thyroid stimulating immunoglobulin. TSIs are a form of immunoglobulin G, or IgG, and they can actually bind to the TSH receptor and mimic TSH itself, increasing the release of T3 and T4. In mild cases, though, TSI levels are often normal or high normal, so it becomes really important to compare those levels with T4 and T3, as well as the symptomatology of the patient. In Graves, we also have increased thyrotropin receptor antibody, or TR antibodies, and these are antibodies to the thyroid stimulating, or TSH receptor itself on the thyroid, and they also mimic TSH. So again, they direct the thyroid to produce more T4 and T3, lower that TSH level. These levels of thyrotropin receptor antibodies, they're far more sensitive, and they're usually present in mild cases of Graves. The key diagnostic test, though, if blood work is unclear, is the radioactive iodine uptake test, and if the uptake is high, then thyroiditis is active. At the other end of this autoimmune spectrum, we have Hashimoto's thyroiditis, whereby thyroid function again is low. So here, as we know, TSH is high, T4 and T3 are usually low, but the main diagnostic criteria is the presence of antibodies to the peroxidases TPO, or thyroid peroxidases. Antibodies to thyroglobulin are also seen, but the strongest indicator of Hashimoto's are the antibodies to TPO, and thus a great reduction in the production of T4 and T3. These are really, really important to follow in your patients, especially those who have a family history of thyroid disease or a family history of autoimmune diseases, or even just low thyroid symptoms, because the levels of these can be elevated in Hashimoto's and goiter up to 7 years before diagnosis, and even up to 7 years before any alteration in TSH levels. These antibodies, they cause an infiltration of lymphocytes into the thyroid, slowly altering its health. And these antibodies or lymphocytes are actually seen in people with absolutely no thyroid symptoms and only really low levels of antibodies. So it shows us how insidious and dangerous these antibodies are if they're left untreated. So we know how toxins directly affect the thyroid. We know that the immune system directly attacks the function of the thyroid, but what stimulates the immune system to do this? Well, it's stress. And chronic stress has a cyclical pattern of dysfunction that occurs between the thyroid and the HPA axis, that hypothalamic pituitary adrenal stress axis. And as we can see, the hypothalamus and pituitary are involved in both sides, and you can't just stimulate one side of this equation. And once we're stuck in this pattern, unless we treat both sides of the cycle, we'll never fully treat either condition. Just like antibodies to TPO and TG, the thyroid globulins, which are seen well before clinical manifestation of any thyroid disorder, an elevated TSH and a lower T3, which is called low T3 syndrome, is seen in people with chronically elevated cortisol well before hypothyroidism has fully taken its hold. And this is considered subclinical hypothyroidism, and stress is the #1 cause of it. The TSH is pushed up via the pituitary stimulation from the HPA axis overdrive. The T4 is low normal because most of it gets converted into reverse T3, that entirely inactive version of T3. And the T3 is slightly below normal again because things are getting pushed to reverse T3. And any kind of stress can do this. Even the physical stress of exercising to exhaustion increases cortisol enough to reduce thyroid response for the next 24 hours. And we look at exercise as a good thing, but like most things, everything in moderation is what we need. Chronic stress also impacts the thyroid in a variety of other ways. One of the most powerful is through the increased production of inflammatory cytokines. These certainly served a purpose when we were hunting, but under chronic stress, which we have today, versus the periodic cortisol secretion, which we had as hunter-gatherers, that cytokine production is continual, and these cytokines inflame the thyroid receptors, making them less sensitive to the hormones, and eventually damaging them so much that they're unable to bind the thyroid hormones at all. Stress, in its attempt to save the body from danger, stimulates the immune pathways. And once again, this was really great and needed when we were hunting, because if we were cut while we're hunting, we want to mount an immune response to heal that. However, with chronic stress, the immune system is stimulated so strongly and continuously that it sets off the autoimmune pathways, resulting in a direct production of thyroglobulins and TPO antibodies. And finally, chronic stress increases or alters the relationship between TPH1 and TPH2 pathways in the GI tract. TPH1, as we know, is all the killing pathways. It's the monocytes, the neutrocytes, the phagocytosis, the macrophages, everything that sort of kills the bacteria and the viruses, etc., in the GI tract. TPH2 pathways are those inflammatory pathways. And what happens with chronic stress is that it favors the TPH2 pathway, and it starts to create so much inflammation in the GI tract that it begins that slow process of leaky gut syndrome. This then allows particles of food, such as dairy or gluten, to pass through. And once they've passed through into the blood, well, our immune system gets all excited, stimulates those autoimmune antibodies, and then they go looking for other targets in the body. And the thyroid is one of the favorite targets of autoimmune antibodies. So once again, we see this cyclical pattern. Cortisol increases those cytokines, especially interleukin-1 beta, interleukin-4, 17, and interferon. This triggers T helper cells to then infiltrate the thyroid, creating inflammation and tissue damage severe enough to initiate both Hashimoto's and type 1 diabetes. These diseases are physical stressors on the body, which then increases the cortisol again, and that whole cycle goes around. Stress also impacts the thyroid via estrogen. Prolonged stress increases estrogen levels via the alterations in FSH and LH from the pituitary stimulation in that HPA axis. High estrogen levels, they increase levels of something called thyroid binding globulin. And thyroid binding globulin will bind the thyroid hormones, and when they do that, for all intents and purposes, the thyroid hormones are basically deactivated because they're not free to then do their normal job of being converted into T3, nor can they be stored in tissue for later use. Also of great importance is that estrogen will increase the expression of adenomas and carcinomas, which generally like to attack the thyroid as well, and this becomes even more dangerous for thyroid health. There's also another reason why, though, inflammation is such a significant trigger for autoimmunity. Geographically speaking, the HLA genes are almost right on top of the TNF alpha genes, that inflammatory cytokine. So when TNF-alpha is turned on, as it is during infections or injury or detoxification, it easily stimulates the production of HLA antibodies through the HLA genes just merely by proximity. TNF-alpha also greatly stimulates interleukin-6, that other dangerous inflammatory cytokine, which then further increases both TNF-alpha and the HLA genes, increasing the initiation and the progression of all autoimmune diseases. And this is one of the reasons why we see autoimmune conditions tag teaming together. It's not a coincidence that pernicious anemia is seen in so many cases of autoimmune thyroid disease. In fact, 45%, so nearly half of patients with an autoimmune thyroid disorder, also have antibodies to gastric parietal cells, those cells that secrete the intrinsic factor needed for B12 absorption. And similarly, the reverse is true. 14% of patients with pernicious anemia have hypothyroidism. And celiac disease is 3 times more common in patients with autoimmune thyroid disease. Why? Because they produce antibodies against transglutaminase. These antibodies in turn bind onto the thyroid cells and increase thyroid pathology. At the start, we saw that genetics contributes to 80% of thyroiditis. And as Denise says, you'll rarely find me giving any lecture without putting genetics in there because it's so near and dear to my heart, but it is also what creates us. So let's take a look at some of these genes. That by no means is this an inclusive list, but we only have an hour together. So the first is TSHR, or thyroid stimulating hormone receptor gene. This is a gene that makes the proteins that form the TSH receptor. The A allele is the normal allele, but this time actually the normal allele is the one that's associated with Graves' disease. And the G allele is the variant allele, but it's the one that's actually not associated with thyroid disease. And in fact, being homozygote AA, so taking an A allele from each of your parents, or heterozygote AG, has a 1.3 times risk of developing Graves' disease. Why? Because they produce very little normal messenger RNA for the TSH receptor. They also have abnormal T cell activity in the thymus that produces much more activity. So there's 2 main mechanisms behind this gene. And the central mechanism, the first main mechanism, deals with T cells. And under normal conditions, meaning a normal stress response and normal immune response, T cells are turned off. We don't need them. But not with the A allele. They actually remain active and far more active all the time. And so in response, they stimulate the production of something called a TSHR reactive T cell. This is a type of cell that's very damaging to the receptor itself, but it also stimulates autoimmune substrates against the TSH receptor. And this is the central mechanism behind thyroiditis in this gene. A peripheral or secondary mechanism also exists. And here the A allele produces an abnormal type of messenger RNA for the thyroid or TSH receptor. So it creates a receptor that's kind of abnormal looking, which of course, whenever there's something abnormal looking in the body, it excites the immune system to go over and kill it because it doesn't recognize it. So once again, we stimulate antibodies against the TSH receptors, and this is another hallmark of Graves' disease. The next gene is DIO1, or deiodinase 1, and this is a gene that produces the enzyme deiodinase that removes the iodine atom from T4 to make T3. There are 3 DIO genes coding for 3 different DIO enzymes, 1, 2, and 3. But the 2 alleles for DIO1 are C and A being the variant allele, which has lower enzyme production and function. So this clearly then lowers the conversion of T4 into T3 and reduces the free T3 to free T4 ratio. It's important to note, though, that this isn't the enzyme that converts T4 into reverse T3. That's DIO3. DIO1, 2, and 3, they all work in tandem together, but they're stimulated during different times of normal and pathological thyroid function. They also have different locations in the body. D1 and D2, they're activating enzymes. So they're going to take T4 and convert it into T3. And D1 is found in the liver, kidney, thyroid, adrenals, and pituitary. D2 is in the skeletal muscle, central nervous system, pituitary, thyroid, and in our brown fat. D3 does the opposite. It inactivates, so it takes T4 and puts it into reverse T3 rather than T3. And it's only in the central nervous system and in the placenta. So this is just a quick graph of showing what the variant alleles would do with D1 and D2 because we are not getting that production of the enzyme. We have less D3 production, so we have higher T4s, and we have the opposite with the D3. They're taking that T4 and converting it into high levels of reverse T3. CD40, or cluster of differentiating 40 gene, is the gene that encodes for a protein that makes the receptor on antigen-presenting cells in the immune system and on thyrocytes. This receptor is part of the TNF receptor superfamily and has a wide variety of immune and inflammatory effects. T is the normal allele and G is the variant allele. The G allele is associated with increased messenger RNA for the CD4 receptor, particularly within the thyroid. And this greatly augments, though, the immune response with increased T helper cells and B cells that then stimulate the production of cytokines and immunoglobulins, increasing the risk of Graves' disease. So more specifically, the CD4 receptor itself primes T cells directly, gets them all excited and pumped up to work. And at the same time, it increases the replication of B cells. This increase in immune activity increases those production of those immunoglobulins again, which then bind back onto the thyroid and increase in an autoimmune fashion, increasing thyrotoxicosis and cellular damage. The increased B cells stimulate the production of cytokines, specifically NF-kappa B, interleukin-6, and TNF, which once again, as we see, create that cellular damage and initiate that autoimmune disease response, stimulating the need for more messenger RNA through CD40 again, which then stimulates this whole cycle and it goes around. HLA-DBQ1, or human leukocyte antigen gene, produces a protein that plays a critical role in the immune system. This gene is part of the major histocompatibility complex, which is a major set of genes crucial in the innate immune response. The proteins produced by the HLA genes stimulate a series of immune reactions from inflammation to allergenic reactions, asthmatic responses, and tissue degradation. The T allele is the normal allele, and the C allele is the variant allele. The C is associated with increased HLA production, increased inflammation, increased asthma and allergies, which further stimulates inflammation, and as we've seen, autoimmune antibodies. And this is why the C allele has a significant increase in celiac disease, irritable bowel syndrome, and all autoimmune disorders. The reason for the increase in autoimmunity through this gene is that the HLA complex helps the immune system distinguish self from foreign, or rather its own proteins versus the proteins from an invader, such as a virus, bacteria, or an allergen. The C allele generates so much inflammation that the body's own tissues don't even recognize itself anymore. So the body mounts an immune reaction against it, stimulates those autoimmune pathways. And for this reason, this gene is greatly associated with several autoimmune diseases, but the three largest are thyroiditis, celiac disease, and MS. The next two genes deal more with the central nervous system. The first is NR3C2, or nuclear receptor subfamily 3 group C, and this is codes for the mineral corticoid receptor, also known as the aldosterone receptor. However, this receptor has an equal affinity to bind both mineral corticoids, such as aldosterone, as well as glucocorticoids, such as cortisol. So it's no surprise that this gene plays a key role in the activation of the HPA axis, the stress pathways, determining both the strength and the response and the stimulation of that stress response. The normal allele is the T allele and the variant is the C. The C allele is associated with fewer mineral corticoid receptors, which means we have less of a feedback that we can impair in the HPA axis. So we have a continual stimulation, increasing our ACTH, our cortisol, which then leads to a lot of the HPA dysfunction ailments that we see, such as depression, anxiety, ADD, ADHD, which then goes into the autoimmunity. So what's really supposed to go on here is we know cortisol is supposed to bind up into those receptors in the hypothalamus to say, great, I'm done, stop further stimulation of this pathway. When this happens, we take our central nervous system from the sympathetic side to the parasympathetic side. So if we have an abundant number of those receptors on the hypothalamus, it's easier for cortisol to bind in. It's got lots of spots to bind in and increase that negative feedback. But the C allele here has such few receptors that the stress response has a very difficult time turning itself off, and we get stuck in that HPA stimulation, which then, as we saw prior, increases all of the autoimmune factors and starts to push T4 into reverse T3. The next is FKBP5, which is an FK binding protein 5, and this is a protein that acts as a co-chaperone that modulates not only glucocorticoid receptor activity in response to stress, but also a multitude of other cellular processes in the body and the brain and the periphery. The protein produced via this gene helps to oversee the protein folding response, which is when we create a new protein, this protein folding response directs it so that it folds into its perfect position so that it can coordinate its job. It also coordinates immune responses during times of stress and the binding and the sensitivity again of stress hormones into those receptors on the hypothalamus. Once again, also talking about the ability to initiate negative feedback in that HPA axis and shut off the stress response. The C allele is the normal allele and the A is the variant allele. The A allele is associated with increased FK binding protein expression, but this time increased expression leads to a loss of that negative feedback because the folding response is abnormal. So whereas with the NR3C2 gene, that had very few receptors to shut off the stress pathway, here there's plenty of receptors, but they're just the wrong shape or an abnormal shape. So no matter how much glucocorticoid we have to bind into it to say, great, I don't need to keep making this further glucocorticoid production, it can't do that. It can't shut off that HPA axis. And so once again, we see increased anxiety, post-traumatic stress disorder, inflammation, autoimmune reactions, and cytokine production. So we've seen how environmental toxins and stress both affect thyroid directly and its production of hormones. And we've seen how that all affects the immune response, directly attacking the thyroid and further inflaming it. But now what are we going to do about it? Well, one of the best things is thyroid support. This is almost like a multivitamin for the thyroid, and it contains a selection of nutrients that help and support and maximize its function, only at a thyroid level, not a hypothalamic pituitary, but we'll address that as well. So it has vitamin A and C, D, zinc, and selenium, which help maintain thyroid hormone metabolism and produce T3. It has iodine and L-tyrosine, which are needed to produce T4 and 3 and keep it as T3, stopping it to being converted into reverse T3. And it also has ashwagandha and glucolipids, which help maintain overall thyroid health. We also have liposomal glutathione. Liposomal glutathione, another one of my favorite products because it has so many effects in the body from phase 2 detoxification. So it's going to help bind to that bevy of toxins from our environment and clear it out of the body before those toxins start any damage on tissues. It also directly lowers the production of tumor necrosis factor, TNF, as well as interleukin-6. And we know if we lower those cytokines, then we stop further damage on the thyroid, and we also stop further production of autoimmunity. One thing that's really important to note is whenever we're taking liposomal glutathione, you want to combo it by taking NAC or N-acetylcysteine. And you want to do this together because N-acetylcysteine, yes, it is the precursor to glutathione, but glutathione is used in so many places in the body that if we take glutathione alone, most often the body's actually going to break down that glutathione to get NAC to use NAC in different areas of the body. Glutathione is also most active in body tissues, and NAC will increase or pass over the blood-brain barrier and help to detoxify brain tissue, whereas glutathione doesn't have quite that ease to do that. Also important to note that once you open the liposomal glutathione, it should be kept in the fridge. There's also innate immune response. This is one of the newer products with pure encapsulations, and it's a fantastic one. This is designed to promote cell-mediated immunity, so everything from natural killer cells to macrophages. It has astragalus in it to help balance out cytokine production, as well as balance out immunoglobulin G and IgAs, immunoglobulin A. It has andrographis in it, which helps moderate interleukin-6 and interleukin-1 levels. And then it also has reishi mushrooms, and these will help to regulate out polysaccharides for cell-mediated immunity. We also have Sereniten Plus. So Sereniten Plus, as we know, has that decapeptide, that protein sequence, which is isolated from milk, but will not have an allergenic effect because it's only 10 amino acids as long as opposed to 12 amino acids, and the immune system can only identify something that is 12 amino acids long. And here's where we get into targeting that HPA axis and the hypothalamic and the pituitary side. So that decapeptide will reset and rejuvenate all of those receptors around the hypothalamus and the pituitary, allowing those stress hormones to bind back in and shut off stimulation of the HPA axis, and not just slow down sympathetic drive, but actually get the body back into parasympathetic drive. Also have probiotics, so important because we know that in any autoimmune condition, intestinal permeability is weakened as we saw. And those lipopolysaccharides, so those are those components around the bacterial cell walls. When that intestinal permeability is weakened, those lipopolysaccharides can leak into the bloodstream and wreak havoc, particularly on the thyroid. Lipopolysaccharides also inhibit IDO, so that shows us that it's going to have a decrease in the conversion of T4 into T3. So this probiotic combination and dose, which is 50 billion, a nice strong dose, helps to strengthen the gut lining and inhibit those lipopolysaccharides from passing through, and also help to regulate the immune response, preventing leaky gut. So now I'm going to putting all this together, go through a couple of different cases so we see how we can use these things and diagnose our patients. So the first one is a 38-year-old female who gave birth to her second child 2 years ago. She was constantly fatigued, but yet she was anxious at the same time. And she had gained 16 pounds, had a lot of hair thinning, all of which she put down to post-pregnancy. And even though her children were sleeping through the night, she would wake at 2:30 in the morning, that cortisol witching hour. If you've heard any of my other webinars or been to any of my other lectures, that's that time where when we make too much cortisol, we shift that natural circadian rhythm, and rather than cortisol peaking at 6 in the morning, it peaks at 2:30, and it wakes us up, and then we have that difficult time falling back asleep. When we looked at her labs, her TSH was high normal. She had a lower T3 and a slightly lower T4. So when we see a low T4 and a low T3, we know that that T4 is not getting converted into T3. So where was it going? Well, she had a high normal reverse T3. She also had high TPO and thyroglobulins, so we know that that's starting to recruit that autoimmune side. And on doing her orthostatic blood pressure, that's again that test of taking blood pressure from lying to standing to measure the adrenal response, she was making 3.3 times the normal amount of stress hormones. So what do? We're going to use that thyroid support complex twice a day on an empty stomach. Because of the herbs in this, we want to use that on an empty stomach. We're going to get at that HPA, that central nervous system response, through the Sereniten Plus twice a day, also empty stomach. We're going to reset that sleeping pattern and push that cortisol back to 6 in the morning and bring melatonin to the forefront, because cortisol inhibits melatonin, which should peak at 2 in the morning and help us sleep. So here we're going to use melatonin SR, the time release, just one before bed. And then we're going to get at that autoimmune side, which is coming in with the innate immune response, 1 capsule twice a day, empty stomach. 10 days later, she started feeling calm, but she started having more energy. 2 weeks later, she was sleeping through the night, about 75% of the time. 2 weeks later, she'd also dropped 3 pounds. And again, we didn't even change her diet here. 2 months later, she had dropped 17 pounds. Her energy was back in full. Hair stopped falling out, but wasn't growing back yet. And it's one thing that you'll notice anytime hair is falling out. The offending factors as to why it falls out, whether it's thyroid, whether it's low iron, high testosterone, high cortisol, they're a result of what happened 3 months prior. And once you rebalance everything involved in hair loss, it takes 3 months to start initiating new hair growth. It'll stop falling, but the new growth won't come back for about 3 months. 3 months later after that, all of her labs were normal, her orthostatic blood pressure was back to normal, and her hair began growing back. The second study was a 51-year-old female who was diagnosed with hyperthyroidism 7 years earlier. She was on desiccated T3 and levothyroxine, yet she completely remained symptomatic. She never felt like herself. She always still felt hypothyroid. Her doses were adjusted almost every year because of this, and medication had been changed twice over the 7 years. She gained 34 pounds in 7 years, despite a quote perfect diet. It was a very well-balanced diet, and she was always exhausted with headaches and constant abdominal bloating. It was important to note, though, that she lived in a city, and on weekends, so it increased exposure to certain toxins, and then on the weekends, she had a weekend home up in the country, which is right by farmland, so a lot of pesticides on either side of her. So here we saw her TSH was high, even despite her meds. Her T3 was low, T4 was normal, because she was converting things into reverse T3 here. She had normal TPO and thyroglobulins, but her inflammatory markers and her liver enzymes were really high, the ESR, AST, and ALK Phos. So she hadn't recruited the autoimmune side, but she'd definitely gone down the inflammatory toxic side here. So here we need to help her get those toxins out, and we're going to use that liposomal glutathione with that NAC, tag teaming both of them, 1 capsule twice a day, empty stomach. We're going to get back some health within the GI tract there to downgrade that inflammatory response with the ProBio 50. Here we did 2 per day with food for 8 weeks, and then after 8 weeks dropped her down to 1 per day. And we're also going to use that Thyroid Essentials, 2 capsules twice a day on an empty stomach. Follow up here, 1 month later, her bloating had been reduced by 50%. A month later, she had also dropped 8 pounds. And once again, didn't do anything with her diet. We're just changing different variables that control the metabolism here. 1 month later after that, she had only had 2 headaches. 3 months later, her TSH was mid-range normal. T3 was low and normal, and reverse T3 was normal. Her ESR and liver enzymes were also normal, and her energy was back up to 80% of what she said. She said she felt like herself again, and she had lost 30 pounds, which is even more than she had gained. So you can see that treating the thyroid is not always about just a specific using a thyroid medication, because that often, as we saw with this last case, really wasn't the issue here. We have to treat all the factors that affect the thyroid. And that's where our genes can help us direct things, but also our blood levels and knowing what to look for in patients and different symptoms. Because we always have to marry the symptoms with the patient, with their genetics, with their labs to get a complete workup together. So I hope that you can take home something from today and put this into your protocols right away. And I welcome any questions if there are.